The title of my talk is Meta-analysis of randomized clinical trials to assess weight gain and sex differences with INSTI or TAF-based regimens in antiretroviral treatment-naive persons living with HIV infection. Here's my disclaimer. Previous studies raised concerns that certain HIV drugs may cause excess weight gain and lead to adverse health outcomes such as cardiovascular disease and diabetes. In women, INSTIs and TAF-based regimens were also associated with greater weight gain compared to controls. The ADVANCE trial was designed to evaluate the efficacy and safety of DTG compared to EFV in a South African population, where approximately 50% of the enrolled population was female and 99% were Black, and at the randomization, 35 to 37% were overweight or obese. However, increases in weight gain were the highest in women and appear to be progressive. Our analysis was designed to confirm if INSTIs or TAF-based regimens for treatment of HIV infection led to excess weight gain compared to controls, and if sex, race, or other baseline factors increase the risk of weight gain when receiving this ARV treatment. We selected randomized clinical trials for treatment of HIV infection in treatment-naive subjects that was submitted to FDA to support initial approvals or major labeling changes between 2011 to 2020. Mixed effect models were used to evaluate associations between INSTIs or TAF regimens and weight change through week 60 following ARV treatment, with baseline weight and study effects adjusted in all models. We assessed the associations of baseline factors and weight gain. The baseline factors include sex, race, CD4 cell count, HIV viral load, and a BMI category. Logistic regression models were used to assess odds ratio of weight gains of more than 10% of baseline weight at week 60. Here are the lists for studies in INSTI was non-INSTI dataset and TAF was non-TAF dataset. Non-INSTI group contains NNRTI or PI regimens. Looking at the demographics and the baseline characteristics, there are 2231 subjects enrolled in INSTI was non-INSTI dataset, 3228 subjects enrolled in TAF was non-TAF dataset. Both datasets had 13% females. Whites were the majority. 25% were Black in the TAF was non-TAF dataset, 19% were Black in the INSTI was non-INSTI dataset. Most of the trial participants at baseline had a stage 2 CD4 cell count, less than 100,000 copies per mil HIV RNA, and a normal BMI. For analysis of racial subgroups, we selected the white and Black races because other races did not have a sufficient number of participants to show meaningful results. Here are the least square mean weight change plots with weeks on treatment. On the left side of the slide, the graph shows the participants who received INSTI in green and the non-INSTI group in gray. We were able to observe that participants who received an INSTI regimen gained more weight than those who did not. On the right side, there are two graphs showing weight change over time for males and females. In our analysis, females did not gain more weight on an INSTI regimen compared to a non-INSTI regimen. On the left side, we did not observe that Blacks gained more weight on an INSTI regimen compared to a non-INSTI regimen. On the right, weight gain was not observed in Black females receiving INSTI was non-INSTI regimen, nor compared to white females receiving INSTI regimen. On the left, participants who received TAF in yellow color gained more weight than those who did not in gray color. On the right, females in the TAF group gained more weight than males, and the females in the TAF group gained more weight than non-TAF regimens. However, these findings was not significant. Similar findings were noted for Blacks versus whites, shown on the left, and Black females versus white females, shown on the right. Looking at our statistical testing results, overall, subject receiving INSTI regimen gained 0.9 kg more weight on average than non-INSTI regimen at week 60 with p-value of 0.002. Subjects receiving a TAF regimen gained 1.8 kg more weight on average than a non-TAF regimen with p-value less than 0.001. Although statistically significant, these findings may not be clinically relevant for some patients. Females in INSTI regimen gained 0.2 kg more weight. Male gained 1 kg more weight. However, the findings and the weight gain differences between female and male were not significant. Similar to the TAF was non-TAF group, statistically significant findings were not seen. Female receiving TAF gained 2 kg more weight was non-TAF, and the males gained 1.8 kg more weight in TAF regimen was non-TAF. The odds ratio of more than 10% weight gain at week 60 is higher in INSTI and TAF regimens compared to non-INSTI and non-TAF regimens. 1.4 for INSTI was non-INSTI with p equal to 0.008, and 1.7 for TAF was non-TAF with p less than 0.1. In females, the odds ratio of more than 10% weight gain at week 60 for INSTI was non-INSTI one is 1.3 with p-value of 0.9. In TAF was non-TAF is 1.8 with p-value of 0.2. In males, the odds ratio of in INSTI was non-INSTI is 1.5 with p-value of 0.06. In TAF was non-TAF is 1.6 with p-value less than 0.001. Here we show changes in BMI category from baseline to week 60. Specifically, BMI category changes from normal to overweight was similar between females and males. More females versus males who were in the overweight category at the baseline become obese over 60 weeks. In the TAF dataset, more females than males went from normal BMI at the baseline to overweight over 60 weeks, and more females went from overweight BMI at baseline to obese. In conclusion, INSTI or TAF regimens were associated with significant increase in weight or odds ratio of gaining more than 10% baseline weight over 60 weeks compared to non-INSTI or non-TAF regimens. Weight gain or odds ratio of gaining more than 10% of baseline weight in females was not significantly different compared to males. Non-significant results were also observed in Black females versus white females, or among other baseline subgroups, such as different CD4 cell count category and the baseline viral load. The non-significant findings may be due to a limited sample size for females or certain subgroups. That's all for my presentation, and thank you for listening.